Calcium channel blockers are used in cardiovascular indications include hypertension, coronary spasm, angina pectoris, supraventricular dysrhythmias, hypertrophic cardiomyopathy, and pulmonary hypertension. In addition to this, they are also prescribed for a Raynaud phenomenon, subarachnoid hemorrhage, migraine headache, and premature labor. Mechanism of action. There are three types of voltage-sensitive calcium channels: L-type long-lasting current, T-type transient current, and N-type neuronal. Calcium channels antagonists block the inward movement of calcium by binding to the L-type long-acting voltage-gated calcium channels in the heart, vascular smooth muscle, and pancreas. There are two major categories of calcium channel antagonists based on their primary physiologic effects: dihydropyridines and non-dihydropyridines. The dihydropyridines in therapeutic dosing have little direct effect on the myocardium and instead are more often peripheral vasodilators, which is why they are useful for hypertension, post-intracranial hemorrhage associated vasospasm, and migraines. Dihydropyridines include amlodipine, clevidipine, felodipine, isradipine, nicardipine, nifedipine, nimodipine, and nisoldipine, most of which end in pine. Non-dihydropyridines. The non-dihydropyridines have inhibitory effect on the sinoatrial and atrioventricular nodes, resulting in slowing of cardiac conduction and contractility. This allows for the treatment of hypertension, reduce oxygen demand, and helps in control the rate of tachydysrhythmias. Non-dihydropyridines include many other drugs. They are diltiazem, that is benzothiazepine, and verapamil, that is phenylethylamine. Absorption. Calcium channel antagonists are absorbed well orally, however many have low bioavailability due to hepatic first-pass metabolism, primarily by CYP3A4. Distribution. Calcium channel antagonists are highly protein bound and many have high volume of distribution. Metabolism. In repeated doses or overdose, the hepatic enzymes responsible for metabolism become saturated and reduce first pass effects, which therefore increases absorption of the active drug. Modified release formulation and saturation of metabolism of these drugs increase the half-life of various calcium channel antagonists. Excretion. Calcium channel antagonists are primarily excreted renally after metabolism. There is the potential for drug-drug interaction because calcium channel antagonists are metabolized by CYP3A4, which is responsible for the metabolism of many other xenobiotics. Calcium channel blockers as tocolytics. Dihydropyridine calcium ion channel blocker are widely accepted in the treatment of premature labor. Their mechanism of action in tocolysis involves the blockade of L-type calcium ion channels influenced by the calcium ion activated potassium channels, beta-adrenergic receptor, and sexual hormones. In clinical practice, most experience has been gained with the use of nifedipine, which efficacy is superior or comparable to those of beta agonists and oxytocin antagonists. Additionally, it has a favorable adverse effect profile as compared with the majority of other tocolytics. Administration. Calcium ion channel antagonist administration can be via the intravenous or oral routes. Tocolysis. Nifedipine is used orally for both tocolysis and cardiovascular treatment. This drug can postpone labor if used early enough. Between gestational weeks 24 to 34, up to 36 weeks. Oral nifedipine 10 mg repeated once or twice after 20 to 30 minutes. 10 mg loading dose, maximum up to daily 60 to 80 mg for 48 hours, followed by 60 mg daily up to 36 weeks. As regards uterine consequence. Side effects. Dihydropyridines, the most common side effects are feeling lightheaded or dizzy, feeling flushed, headache, peripheral edema, that is swelling in limbs. Non-dihydropyridines, these medications are more likely to cause constipation, slow heartbeat, or reduction in heart's blood pumping ability. Many calcium channel blockers can cause gingival hyperplasia. They may also cause an increase in symptoms of gastroesophageal reflux disease or heartburn. Contraindications. Non-hydropyridines are contraindicated in those with heart failure with reduced ejection fraction, second or third degree AV blockade, and sick sinus syndrome because of the possibility of causing bradycardia and worsening cardiac output. Calcium channel antagonists are also contraindicated in patients with known hypersensitivity to the drug or its components. Other contraindications include sick sinus syndrome, except in the patient with an artificial pacemaker, severe hypotension, acute myocardial infarction, and pulmonary congestions. Calcium channel antagonists may cause AV blockade or sinus bradycardia, especially if taken with agents known to slow cardiac conduction. There are reports of dermatologic reactions and hypotension with or without syncope with calcium channel antagonist use. Peripheral edema may occur within 2 to 3 weeks of initiating calcium channel blocker therapy. Use with caution in renal and hepatic impairment. Consider starting treatment at a lower dose. Monitoring. Patients require close monitoring. The improvement of their symptoms of angina or maintenance of their blood pressure is an indication of efficacy. A patient should undergo regular assessment if the clinician is titrating this medication quickly.